Attamoltani. Sati ware kana bodde waan irratti dubbannu bridging healthcare disparities in Oromia, Ethiopia jira. Challenge and opportunities. My main focus is the Western Oromia region. That is where I have a lot of exposure with. I've been going back and forth to that region for about 5 years. I will have some general information about the Oromia and Ethiopia in general, and then I'll focus more in Nejo, Gimbi, and Debidolo and Begi hospitals. Health disparity, my knee is a jaluvi, I'll read it. Gaps in the quality of health and healthcare that mirror differences in socioeconomic and geographic locations and education level. Those disparities go along with our people. Our elders back in Oromia, most of them are uneducated. That mirrors the health disparities, lack of access to basic health care. The people who live in the remote area might not have good access as compared to the people who live in the cities. Disparities in Oromia. Hospitals in Oromia work with limited resources and supplies. There is a huge hospital in every region and every city, and which I'm very grateful for. But those hospitals are not equipped well enough to treat the patient flow that comes through those hospitals. If one hospital has one X-ray machine, one ultrasound, and partial laboratory department, they cannot treat every patient with every disease that comes through that door. Basic medication to treat their patients. This is true, like I said, I have more exposure in Western Oromia, mainly in Wallagga region. They don't have a lot of medication that their patient needs in that area. Either they have to go to Finfinne if they could afford the travel and the money. Otherwise, their other fit is just to pass or die in their village. One hospital serves over 500,000 people, especially in very dense populated cities, Dambidolo, Nejo, Gimbi, and Begi Hospital is kind of bordered with, close to the Sudanese border, so they have a lot of patients, but their hospital is severely equipped, under-equipped and underserved. Patients that have a simple infectious disease that could be cured easily. When I say easily, it is easily for American. You don't hear or you don't see patients die in America for lack of blood transfusion. That happens in the rural Oromia, whether you're in RC, Bale, Borana, or Wallagga, because there is no blood bank in any part of Oromia. There is one in Ambo currently, but they cannot transport the blood in a lot of the remote villages. So you see people die of unknown cause of anemia, and they're not actively bleeding. For those of you who are in the medical field, you know what anemia is, a lack of blood and red blood cell in the body. What are the challenges? Gender inequality. I rarely talk about gender inequality because I did not face a lot of challenge in that regard. But in Oromia, the women tend to stay behind until they get really, really sick to come to the hospital because they're housewives, housemakers, they take care of the kids, they take care of the village, they cook for their husband or the entire family. So until they're bedridden, they don't come to the hospital as compared to the guys or the elders who tend to come to the hospital more frequently than our women in Oromia. Access to basic health care, I think I touched a little bit on that earlier. There might be healthcare centers in rural Oromia, but it's not enough to cover those people. So they lack, and that is one of the challenges, financial constraints. Not everyone affords the simple medication, money to buy malaria medication, money to buy medication for their hypertension or diabetes. A lot of our patients in Oromia are farmers. We do have a lot of business owners, government workers, teachers, and so forth, but the majority of the people in Oromia, regardless of what region they are in, they're farmers and they might not afford that high-paying medications. I'll get back to that. I met a patient about 3 years ago in Nejo that is holding a vial of medication and crying. I asked her what was the matter, and she said, "Look at this." And I looked at a broken vial, and she said, I just dropped it on the floor, and I only had 4 birr qoricha kana bituufi. Amma waan ani ittiin deebi'e qoricha kana akka isheen jettetti jechuu barbaadeen qoricha kana deebisee bituu hin danda'u. Uffatan uffadhu ergifadheen dhufee dhaabattee boosi. And how many of us have $3-4 change in our car? And I'm guilty of that. At least quarter sadii afurnan qabaadha konkolaataa koo keessa parkingiif jedhee. She cannot even afford that to save her child's life from malaria. Yes, we subsidized, covered, bought her medications, but how many of them that we don't see in a very remote village in Oromia and healthcare centers and hospitals, clinics, or those of them who die in their village without even making it to the hospital? Education level. I will put up the data later on. Surprisingly, there are a lot of diabetes in Oromia these days, even in their, on their website. I don't know from where. Dr. Masfin and Dr. Ibrahim might help me on this one. But when you're diabetic, you have to control your diet, what you eat, your insulins, or if you're taking a pill, anti-diabetic pill. Those patients are, like I said, illiterate, most of them. How do they take their insulin? How do they measure it? So they lack education, and then lack of community health care workers, community health workers. They're called extension workers now. They have it in a lot of the rural Oromia that the government trains right out of high school for about 6 or 9 months. They go around the remote village and bring those patients to the nearest health center, whether it is a hospital or a health center or a clinic. So they lack on that because, like, when I say lack, they have it, but it's not enough to cover all those people. Transportation. A lot of our patients in Oromia live in a remote area, like I said. My parents grew up in a remote area where there is no car, so they had to walk to the city. If there is no car, it takes 8 to 9, 10 hours to get to the nearest hospital. Even if there is a car, if they don't have the money to pay for that transportation, it takes them longer. Most of them walk. Opportunities. What has been done, or what are the opportunities that those hospitals or those regions or those cities have to build capacity building in the central level, like working with the regional health bureau, partner through training or logistical support. Training would be a big one for the nurses, the doctors, and the other healthcare workers. We're not there, or not to invent any new wheels, but work with the existing healthcare sector. Free healthcare service for patients. They don't have Medicare or medical in Oromia, but they do offer free health service. For those patients who could not afford. I've seen it in those hospitals that I visited in the last 5 years. You get a paper from qabaleedha yookaan ganda jiraataniiti waraqaa kennamaaf affordii gochuu hin danda'an kan jedhamu. So waraqaa sana gaafa geessanii all their treatment is free of charge. Garuu they have to have that paper. Most of those patients, they don't even know what that paper means. Waan isaan jedhanii waraqaa tolaati kunii jedhu. Si'a tokko tokko achirratti kan barreeffamu qoricha tolaa yookiin yoo ciisuu danda'an kan ciisicha tolaa jedhama. So baay'een isaanii beekan gaafa ciisuuf dhufanii waraqaa tolaan qabaan jedha kuni armee isin ciibsuu hin danda'u jedhama. So that creates an argument between the healthcare professionals and those patients. Continuing education for nurses, doctors, and other healthcare workers. Unless they have a continuing education, they cannot continue with the challenge and with a lot of life-threatening health issues that arises in that community. They have to prepare to respond to an emergency, like if there is a malaria outbreak, if there is a whooping cough outbreak or something. So they need that continuing education. Collaborate with local hospitals. So let's say if there are 4 hospitals within 2-3 hours away, distant radius, all those hospitals have to work together, in which they already do, work. If they don't have a doctor in this hospital, they will transfer the patient to the hospital near to their city. A lot of health assessment needs to be done, control communicable or infectious disease, which is a big thing in our area. I was talking with Dr. Musvin earlier, and when I got the top 10 disease for the last 3 years, HIV was not on it. I'm not saying HIV is not a problem in our area. There is a problem, but somewhat at Gimby government. And then my foundation works directly with Nedjo Hospital, even though we go to Gimby, Biggie, and Mdolo sometimes. That brings me to the foundation that I work for, or that I work with. I don't want to own it because the foundation is not mine. It is for the people. So it is a non-profit organization that was founded to improve access to quality healthcare in Oromia, and Ethiopia's largest and most populous region. One hospital and one city, one patient at a time. This is the mission statement. It's a quality and sustainable medical network that is responsive to the needs of the underserved, vulnerable people for the Oromia region. So we don't just show up to that hospital or to that region saying that, hey, we came from America and we're going to do X, Y, Z for you guys, rather than saying that, what do you guys need? Prior need assessment a year ahead, 6 months ahead. If they tell us we need a new wing built for the hospital, maybe their top priority is a medication, or maybe their top priority would be getting an oxygen supply for them. And so even though they give us a list, doing a need assessment would be like, it's in our mission that we go by their need rather than saying, hey, we're here to help you and this is what we're going to do for you. How do we do this, and how do we achieve what we set out on our mission? Where US trained doctors and nurses will establish strategic partnership with those hospitals, build up capacity building with the local healthcare workers, offer free health education for the people of that region. When I say that region, I'm talking about the general Western Oromia region, which hopefully we'll get to that and then move on to other regions. Other region in Oromia, meaning the RC, the Bali, Shawa, and Harar. And I'm very hopeful and optimistic that we reach those regions soon. And just, it's a little busy screen, but I'm just gonna tell you the top part. Nedjo is a very small town, my hometown, that's where I was born. About 320 miles from Finfinne, but it takes about 10, 12 hours to get there. Approximately about 100,000 people live there. There is one hospital, it's government owned. That is the hospital that I work with. And they have over 500,000 patient flow per year. Facts about the hospital: it serves Nedjo and surrounding village. The hospital has six physicians. They have an OBGYN, that is the most frequently visited department. A lot of babies. Along that, obstructive labor comes. It's a 65-bed hospital. That's how they call it, but it's a 4th room with 8 to 10 beds in each room. This is what the hospital looks like, the waiting area inside the hospital. Medical mission trips. We've done 5 so far. The first one is in 2009, donated a box of medical supplies and treated patients and trained nurses. In 2010, one was a cardiologist that treated a lot of cardiac patients and other illnesses, patients who have other illnesses. An interventional cardiologist in 2011 that detected a lot of congenital heart defect in children who are anywhere from cataract and cleft lip surgery. That is the most recent one. We treat about 170 patients with cataract and 13 patients with the cleft lip. The youngest patient for cleft lip is 6 months, and the oldest one is 55 years old. And he lived all his life with that for 55, and he had to relearn how to smile and how to eat. And I wish they had a speech pathology. If any of you are in here, Oromia could use you for that, because I don't think they have it, especially in the rural area. Other things that we do or I do is collaborating with the University of Kansas Nursing School. There are a group of students that have never been to Oromia. She was born in Shashamane in Oromia. So we met in Nejo, we met in Gimbi, and then she came to Nejo. So she is a professor at University of Kansas. Every year I work with 6 to 8 nursing students where I teach them online once a week about an hour about Oromia and especially state of the health in Oromia region. Last year they did the first infection prevention guideline for Nejo Hospital. We implemented in Nejo, moved it on to Begi Hospital and Gimbi Hospital. So those 3 hospitals are using that guideline. This is the top 10 disease. Mostly this is true for the hospitals that I've visited, even though the order might not be the same. PUD is peptic ulcer disease. It is a top admission. You can admit malaria, busa, CHF, congestive heart failure, AFI, pneumonia, or upper respiratory distress. Along with those disease, education comes along, so we have to educate the locals and the doctors. Okay. 2012, again, upper respiratory infection, skin infection is on top. 2013, pneumonia, trauma, and skin infection. Top 10 mortality is kan dhukkuba baay'eetiin namoonni ittiin du'an waggaa 2013dha. Hypertension, anemia, pneumonia, and respiratory distress. And and the future side or the diagnostic and imaging center, why do we need it? If we have all those disease or all those illnesses, how do we diagnose them or how do we treat them? So in order to do that, my action plan is to build the diagnostic and imaging center. And the future plan is to finalize the diagnostic center that we're hoping to reach about 1.5 to 2 million people in Western Oromia. That goes from Ambo to Asosa. So some parts of Shawa and then the entire Western Wallagga region up until Asosa, which is the Benishangul Gumuz area. Continually trained doctors, surgeons, and nurses. On this one, I'm working with the Rotary Club to work on a VTT, vocational training for nurses and doctors, either bring them here or implement an educational program for the nurses, mainly for the nurses, because I'm a nurse, so I could teach them and I could go follow along with the curriculum. So we're working on that. I had a lot of pictures, I don't know where it went, but thank you so much. Arifat Dendu Baderivam.